All right, hello everyone. My name is Meg O'Mara. I am here with my colleague Brittney Henderson, and we're going to spend the next hour talking to you all about taking care of the post-liver transplant patient in the primary care setting. But a little bit of business here first. We want to let you know that we have no financial disclosures and that the CME office will be reaching out to you after the presentation for you to be able to get your CMEs from our talk today. So to highlight what our learning objectives are going to be is we want to kind of cover post-transplant anatomy and many complications that we see after transplant. We want you to feel more familiar with common immunosuppression agents we use in post-transplant patients and what follow-up and expectations look like for our patients. Then cover some of the common health maintenance items that we like to focus on in clinic with patients on chronic immunosuppression, how we look at infection and how to work that up. And then also for years down the road for some patients looking at non-alcoholic steatohepatitis and advanced fibrosis in the transplant patient. And then quite possibly one of the most important parts of the talk is how to get a hold of us and our coordinators when you have questions in the future. And also a quick thank you to Dr. Avash Kalra for letting us talk in this webinar series, and also to Ms. Lindsay Carter, who without her, we'd all be very lost. So thank you to you both for this presentation today. So before we get into everything, I also wanted to show you just an idea of our transplant volume at University of Colorado. Thank you to Dr. Whitney Jackson for giving us this slide. You'll see that over the past 30 years, our transplant volume really has increased. And something that's pretty unique and great about our transplant program is that we do living donor liver transplant. And we support grafts to not only adult recipients, but also to the pediatric population next door at Children's Colorado. So looking at last year, you might be wondering, what do people even get transplanted for? And as you'll see here, the highest statistic was for alcohol cirrhosis. Of course, with the pandemic, we did see a rise in incident of transplanting for alcohol cirrhosis. And leading up to pandemic, we were seeing a lot more non-alcoholic steatohepatitis, which you often see referred to as NASH. You will notice that hepatocellular carcinoma or liver cancer has a very high percentage of reason for transplant, but that's often not a primary disease. It's often paired with something like hepatitis C, alcohol cirrhosis, or other diseases, not just liver cancer alone. A little under 10% of our transplant patients received a liver and kidney transplant in 2022, oftentimes from polycystic liver disease and polycystic kidney disease, but also with other disease like alcohol cirrhosis complicated with hepatorenal syndrome. And that living donor program, we were able to give 8 liver transplants to pediatric patients and 15 to adults here at University. Another disease etiology that we do transplant for, that we happen to not transplant for in 2022, is Budd-Chiari syndrome. And we also want to highlight that we do occasionally transplant for complications of herbal supplements and other drug-induced liver injury.
Okay, so here's an image depicting what a post-transplant anatomy might look like. Obviously, there are many variables here, and but I wanted to just take a look at this picture and emphasize a few of the surgical connections that are made at the time of a liver transplant. So in red, you have an arterial anastomosis, and this is going to be the donor to the recipient hepatic artery. And then there are often several venous anastomoses. So you need to think about the venous inflow through the portal vein and that surgical connection, as well as the venous outflow. And so that connection could either be to the vena cava or the hepatic vein. That's depicted in blue. Then here in green, thinking about the connection from the donor bile duct to the recipient. And we'll talk more about the bile ducts here in just a minute. On this image, please also note the absence of the gallbladder. That is intentional. All liver transplant patients will receive a cholecystectomy at the time of transplant. So as Meg mentioned, we do both living donor and deceased donors here at University of Colorado. So a living donor transplant is typically performed by taking a healthy donor's right lobe of their liver and transplanting it into one of our recipients. A deceased donor, and that's pictured here in the middle, if you can see my cursor. Then here on the left is a deceased donor, where we take a complete hepatectomy on a deceased donor and implant that into a transplant patient. If we have a smaller patient, sometimes we're able to take a right lobe from a deceased donor and implant that into a patient, and then take that left lateral portion of the deceased donor's liver and give that to a pediatric patient across the street at Children's. So back to the biliary anastomoses. When thinking about the biliary system, it's helpful to know their surgical connection. So here on the left, you see duct to duct. This is the most common type of surgical anastomoses. And we take the donor bile duct and connect it to the recipient bile duct. And then here on the right is an example of a Roux-en-Y. So this is when you take a donor bile duct and connect it to the recipient's bowel. Here, this is the jejunum. Occasionally, you can connect to the duodenum as well. This connection is obviously a bit more complicated and requires manipulation of the bowel to make this anastomosis. So why would we do this? Sometimes this will be performed if the patient has underlying biliary disease, such as patients with PSC, making their own bile ducts a poor point of connection, or if there's a significant size discrepancy between the donor and the recipient.
So now that you have a better understanding of the biliary tree and a liver transplant recipient, this is a good time to talk about some common post-liver transplant complications. One of the complications we can see is called ischemic cholangiopathy. And this can derive from either hepatic artery thrombosis, and the hepatic artery is what gives us the good nutritious blood flow to the liver, or for patients that receive a deceased after cardiac death liver transplant, or what we call a DCD, if you ever see that in our notes. And DCDs can have less warm ischemic time and have some injury to the liver tissue before it's implanted. Not all DCD recipients will have an ischemic complication, but they tend to be more prone to it than someone who gets a deceased after brain death donor. You'll see here on these pictures here, this is what a normal cholangiogram would look like. But when you have ischemic cholangiopathy and compromise of that blood flow, you can start noticing issues with the biliary tree. So in this slide, you'll see on day 14, you're starting to see some stricturing, some narrowing, and also the dilation of the biliary tree. And in this patient at day 36, you see that the biliary tree just really looks uneven everywhere. This can also look like PSC. So if you have a transplant recipient that has imaging and there's a comment of resembling PSC, something you might want to think about, or that we think about, is has there been any hepatic artery compromise to this patient? Another area where we can have a bile duct problem is if there's just an anastomotic stricture. So in either that duct-to-duct anastomosis or in the Roux-en-Y anastomosis, where the bile ducts are sewn together, there is risk for narrowing there. Patients sometimes need to go for an ERCP to have those strictures either dilated, have sphincterotomy, or have a stent placed. Some transplant patients can have one ERCP and one stent and have it taken out and do fine, and others can require multiple ERCPs. And sometimes even metal stents have to be placed, or patients might have to get a percutaneous drain to really open up the biliary tree. Now, what's important in the primary care setting for you folks to know is if this patient comes to clinic and they've said, I've had a bile duct problem, after transplant, or maybe even if they haven't and they're reporting right upper quadrant abdominal pain, itching, fever, chills, they've noticed that they're more yellow, or you notice on their lab work that their bilirubin or alkaline phosphatase is more elevated, that's when we start thinking about a bile duct problem. If they have a stent already in, is it occluded, or are they having cholangitis, which is an infection of that biliary tree? Now, the patients with ischemic cholangiopathy, we might see a chronic elevation of their alkaline phosphatase, but we learn what their new baseline and their new normals are and look for changes in that number. But cholangitis is a common thing we'll talk about throughout this presentation and to think about in a liver transplant patient. Other complications, unfortunately, can be recurrent disease. So in patients with more of an autoimmune reason for liver transplant, such as PSC, PBC, or autoimmune hepatitis, these patients can unfortunately get recurrent disease. Now, this isn't very common early post-transplant, but we do see recurrence of non-alcoholic steatohepatitis early post-transplant, And unfortunately, some patients return to alcohol use and have similar complications as they did with their native liver. Another common complication is rejection, which we'll talk about here a little bit more later. Infections, of course, on immunosuppression, these patients are more prone to infection. And then PTLD, or post-transplant lymphoproliferative disorder. This is a type of lymphoma that post-transplant patients are more susceptible to, especially if they have any history of Epstein-Barr virus viremia, or EBV. And these patients would often come to clinic and say, I've had night sweats, unexplained weight loss, fatigue, loss of appetite, just kind of those B symptoms that you think about malignancy. We start thinking about PTLD much sooner.
So now to talk some about immunosuppression. Liver transplant patients will begin their immunosuppression at the time of transplant and continue for the rest of their life. So the most common class of immunosuppression that we'll talk about are calcineurin inhibitors, and that will be the tacrolimus and cyclosporin. And I found this kind of cool little acronym that spells out tacrolimus that talks about the multitude of side effects that you can see on this class of medications. So calcineurin inhibitors work by inhibiting T cell activation. And then side effects that you see with this class of medication. So T for tremor, so the neurologic side effects. So tremor, headaches, peripheral neuropathy can all be common. Alopecia, so hair loss on TAC and cyclosporin. Cardiovascular side effects. It is common to see elevation in blood pressure after initiation of immunosuppressive agents. So monitoring patients who may have actually struggled with low blood pressure as a cirrhotic, now coming back to clinic with blood pressure elevations. Renal insufficiency, we monitor kidney function very closely in our post-transplant patients, and realizing that some patients are more sensitive than others to calcineurin inhibitors, and we'll start to actually see renal insufficiency. And that can even be a reason that we will transition to some of the other immunosuppressive agents. We'll talk about that more in just a minute. O for oncologic or skin cancer risk. Being on tacrolimus or cyclosporin increases your risk for skin cancer pretty significantly. Plus living at elevation, these patients have significantly increased risk, and we rely on the help of dermatologists to help us monitor for skin cancer. Elevation in lipids. So monitoring for cholesterol panel annually, and being aware that these medications can actually contribute to a patient's hyperlipidemia. Insulin-dependent diabetes, so elevations of blood sugar, regardless of whether these patients had diabetes going into transplant. Simply by being on a CNI, they do have an increased risk of diabetes. And then electrolyte abnormalities, so magnesium wasting, elevations in potassium can be seen in patients on calcineurin inhibitors. U is for uric acid elevation. So particularly in patients with a history of gout, sometimes their gout flares can actually become exacerbated post-transplant on these medications. And lastly, seizures. So tacrolimus in particular can lower the seizure threshold. Typically, if this is going to happen, it will happen early post-transplant. And if it does, that's typically a reason that will transition them off of the tacrolimus to a different agent. So we talked about calcineurin inhibitors, and now back to this busy slide. So next, we'll talk about anti-proliferative agents, the first of which is mycophenolate. Mycophenolate is, brand names are Myfortic and Cellcept, and this medication works to prevent B and T cell production. So side effects of mycophenolate, you can see pancytopenias, so anemia, thrombocytopenia, leukopenia are all very common on these medications. You can have GI side effects on both, though typically this will be more common when patients are on Cellcept. Myfortic is an enterically coated formulation of mycophenolate, so in theory should have a little bit less of the GI side effects. And then also realizing that this medication is a bit oncogenic. So in patients with a new diagnosis of cancer, we will typically try to get them off of the mycophenolate. One important point to make about mycophenolate, it is very teratogenic. So in female transplant patients of childbearing age, this is very important that we want them on contraceptives while they're taking this medication. and then definitely discussing with us if they are desiring to start a family that we would need to transition their medications off of the mycophenolate. So the next anti-proliferative agent that we'll discuss is azathioprine. This medication works to inhibit DNA and RNA synthesis in the T cells. It has this similar profile as mycophenolate with the pancytopenias, so something to be aware of. And it also carries a low risk of pancreatitis. Imuran has the benefit of decreasing intestinal inflammation. So we will commonly work with our GI colleagues and use this in patients who also have a diagnosis of IBD. So next, the mTOR inhibitors. So this would be sirolimus and everolimus. These medications work to prevent T cell replication and carry some side effects. Not surprising. So mTOR inhibitors, you can see protein in the urine. So we monitor for protein in the urine annually on these patients. We can see elevation of triglycerides, so monitoring lipid panel annually is important. Sometimes when you start these medications, patients will develop mouth sores, and that is actually related to the medication, so something to be aware of in the primary care setting. And then pneumonitis, while not super common, if that is seen on imaging, we'll work with our pulmonology colleagues that this can be an indication to actually stop the mTOR inhibitor. The last point I want to make about this class of medication is that it delays wound healing. So we try to emphasize this to patients who are on these medications, but good for the community providers to know as well. If a patient is on an mTOR inhibitor and planning to undergo a major surgery, like an open abdominal surgery, we will typically transition them off of the mTOR in preparation for surgery to ensure that they have adequate healing post-operatively. Next, corticosteroids. So we use both oral and IV forms, prednisone, solumedrol. This is typically used in patients with autoimmune features of liver disease and also for treatment of rejection, as we'll talk about below. And then remembering that there are pretty significant blood glucose elevations in patients on corticosteroids. So definitely trying to minimize their use in our diabetic population. Lastly, thymoglobulin. Thymoglobulin is an anti-thymocyte globulin that's derived from rabbits, and it is given as an IV medication. It is a very strong immunosuppressive drug and is important to know about because if your patient has received this recently, their risk of infection is significantly elevated. Typically, when patients are given thymoglobulin, we will give them prophylactic antibiotics for a period of months after administration to help reduce the risk. But definitely your differential would be broader if a patient had recently received thymo and was presenting with fever. The reason that we would give thymoglobulin is for rejection, and we'll talk about that in a minute as well. So I wanted to list a few of the common drugs that interact with tacrolimus and cyclosporin. Calcineurin inhibitors do work, they're metabolized via the cytochrome P450 enzyme. So definitely the list of their drug interactions is extensive, but just a few to touch on here. So fluconazole, macrolide antibiotics. So that's going to be azithromycin, clarithromycin, erythromycin, and then verapamil can all cause elevations of tacrolimus or cyclosporin levels. We generally avoid the macrolide antibiotics for this reason. Fluconazole and verapamil, we do have patients that use them, but if it's starting or stopping these drugs, we just ask that the patient or the primary care provider get in touch with us so that we can make appropriate dose adjustments to their medications. Next, Paxlovid. So the COVID pandemic taught us many things, but we found that Paxlovid actually causes marked elevations of tacrolimus or cyclosporin levels, even to a toxic level. So we just generally say that for all liver transplant patients, we avoid Paxlovid completely. So next, acute T-cell mediated rejection. This slide has a lot of words. I mainly want to discuss the things that I circled in red here. So it's very important for our patients to have routine labs, both to check immunosuppression levels and to monitor their liver function tests. An acute rise in liver enzymes would be worrisome for rejection. And if that elevation persists, we'll often proceed with a liver biopsy. So when evaluating liver tissue microscopically for rejection, we're looking for portal inflammation, bile duct epithelium inflammation, and venous endothelial inflammation. So kind of 3 categories that are scored from 0 to 3, 3 being the most severe forms of rejection. And that adds up to the Rejection Activity Index, or RAI, with a score from 0 to 9, 9 being the most severe rejection. So how to treat rejection? So the most mild forms of rejection, potentially an RAI of 1 to 2, you would even just treat with increasing your baseline immunosuppression. So whether that be increasing the dose of the mycophenolate or increasing the dose of the tacrolimus would be kind of a reasonable early phase rejection of where to start. Next, we will sometimes use oral steroids, and then solumedrol given IV for 3 doses is kind of our baseline mild to moderate rejection treatment. And then remembering those most severe forms of rejection, we will treat with thymoglobulin. So that's the bigger IV medication. Patients will be brought into the hospital for initiation with thymoglobulin.
So now you might be wondering, how often should we be seeing these patients, and how often should you folks be seeing these patients? Early post-transplant, patients are seen in the surgical clinic once or even twice a week. And as they heal from surgery, they no longer have staples and drains, we start extending that out. But in the early post-transplant phase, we're seeing these patients very, very frequently. It's really important that we get a good partnership with primary care team as patients start to transition back over to the hepatology service with Brittney and I and our attending physicians and coordinators, as that's when we start looking at health maintenance stuff post-transplant. We always say that we've exchanged your primary liver disease for potential of many new chronic diseases that can be consequence of being on lifelong immunosuppression. So we encourage our patients to come back to see primary care providers even as early as 3 months post-transplant. And if you've seen one of our transplant patients in clinic and you haven't seen a recent note from us, please encourage them to call and schedule with us, but hopefully we've already reached out to them as well. We also like to send our clinic notes to you folks and have for you guys to send to us as well. That way we can just keep on track with maybe any early red flags we're seeing as either complications from immunosuppression or complications with graft function. The other hard thing is with these patients, you see them in clinic and you say, okay, you're not feeling good today. Is that because you're human and some days we just don't feel good? Or do you not feel good because there's a transplant or an immunosuppression problem? So we really want to encourage partnership between our teams to make sure we're taking really good care of these patients. As Brittney described earlier, chronic kidney disease is a big problem we see in the world of liver transplant. In fact, out of all the other solid organ transplant groups, aside from kidney transplant, we just tend to see the most chronic kidney disease. So we want to be watching for not only keeping tacrolimus levels appropriate and minimized as much as possible, but is hypertension well controlled? Is diabetes well controlled? Are these patients adequately hydrating and not using Advil and ibuprofen? So this is a big thing that we look for and monitor just as closely as we do liver function tests after surgery. Oftentimes our patients end up seeing nephrology as well to help with their kidney health long-term. And some patients may even require kidney transplant down the road post-liver transplant. Oftentimes we're able to change immunosuppression to try to limit calcineurin inhibitor exposure and try to limit kidney disease. But unfortunately, some patients end up needing that kidney transplant. So other important health maintenance considerations. So we'll start with bone health. It's really important for our transplant patients to get a bone density scan at 1 year post-transplant. And there's a couple reasons for that. Part of it can be from immunosuppression, such as the calcineurin inhibitors that can really decrease bone mineral density in the first year of transplant when they're on high levels of this medication. Prednisone, of course, can lead to bone disease as well. We try not to use prednisone as much, but for some patients with rejection or autoimmune hepatitis after transplant, they may need to be on this for a longer period of time. And also considering a patient's native liver disease. Liver disease such as PBC or primary biliary cirrhosis is often associated with osteoporosis. We think about our PSC patients who often have inflammatory bowel disease and have had issues with absorbing vitamins and nutrients over the years. They're more prone to having bone disease issues. And also thinking about our patients with alcohol use disorder. Those patients in the years of drinking may not have had good nutrition as well and poor absorption. So there's a lot of different reasons that patients can have that bone disease. And really, we want to focus on preventative medicine. So if we're noticing osteopenia in your 35-year-old male sitting in clinic, which you wouldn't even think about bone disease before, we want to make sure we're getting good, adequate vitamin D levels. And if someone already has osteoporosis at a young age, thinking about getting them to endocrinology for help with management of their bone health can be really crucial. Another thing to think about is thyroid function. We have noticed that some patients right after transplant have an elevated TSH. If people are asymptomatic, we do tend to give it a little time to see if that comes down on its own. But if you think about patients that have more of an autoimmune-like reason for their liver disease, they might have more autoimmune disease elsewhere in the body, whether it be inflammatory bowel disease, thyroid function. So spot checking a TSH is important after transplant. Other thing, and we'll talk about this a bunch in the rest of the talk, is metabolic risk factors. We want a lot of help from the primary care community in managing metabolic risk factors. As Brittney described, we give these patients immunosuppression that can really make some of this stuff much more challenging to manage. And we also have patients that finally feel good after transplant and they actually want to eat real food again and enjoy doing that. So what's important to remember is that these patients are at increased cardiovascular risk for things like heart attack and stroke. So we want to make sure blood pressure is really well controlled. We tend to start with amlodipine post-transplant for hypertension management. We're not opposed to patients being put on ARBs and ACE inhibitors. We tend to use an ARB instead of an ACE inhibitor only because if they're transitioned to an mTOR inhibitor down the road, there can be a slight increased risk for angioedema in patients on both mTOR inhibitor and ACE inhibitor. Of course, we can change blood pressure medication around if we change immunosuppression, but if we can start with an ARB, then that just makes one less med change whenever we're doing immunosuppression changes. Another important thing is looking at a cholesterol panel. Again, these patients can re-nourish post-transplant and maybe need a little time to get diet under control. We're big advocates for lifestyle and dietary changes first, but we want to keep the low density lipoproteins less than 100, and if a patient is diabetic, less than 70. We also want to drive a point that statins are not contraindicated post-transplant. We love statins. I mean, one might argue that they should just be in the water for a post-transplant patient, but we just want to know if they're being started. Some can interact with immunosuppression a little bit, so we would want to make sure we know what's being started. And we monitor liver function tests a couple weeks after starting a statin. So we like to use them, and we end up getting most of our patients on one post-liver transplant. And then, of course, diabetes management. Everyone wants that beautiful A1C less than 7. That can be a little challenging when we're using calcineurin inhibitors. It can be really challenging when patients are needing solumedrol and prednisone. But we have seen a lot of providers starting GLP-1 agonists, which have been really beneficial for the post-transplant population. Other important things, and Brittney alluded to this a little bit before, is with reproductive health. We really encourage women of childbearing years to be on 2 forms of birth control, especially when they're on mycophenolate, given how teratogenic it is. If you have a post-transplant patient with mycophenolate on their med list and they are positive with their pregnancy tests and it's unexpected pregnancy, please call us right away, as we need to stop mycophenolate and discuss if an alternative agent needs to be started, such as azathioprine. We can make immunosuppression safe for conception, pregnancy, and breastfeeding. We just want to be sure that we do it in a safe way. We ask that women not get pregnant the first year of transplant, really because we want to make sure that graft function is stable, immunosuppression is stable, and if we need time to get someone off mycophenolate, that we have, again, just really good graft function going into having a healthy pregnancy for both mom and baby. Also, these women should be seen by perinatology for high-risk OB, just given the complications with their medications and having a big abdominal surgery. Then the other thing that's really important is just malignancy screening. As we talked about, skin cancer risk post-transplant is significantly higher. I always tell my patients that immunosuppression is not forgiving of sunburns of the past. And if you were a sun bunny in your previous transplant life or prior to transplant life, that your risk of skin cancer is much higher. So we can do some basic skin checks. In the primary care clinic, you can as well, but we really want these patients to see a dermatologist because it's usually not if, it's when they're going to get a skin cancer and need to have that removed promptly. We sometimes change immunosuppression if we're starting to notice a trend of skin cancers in these patients. The mTOR inhibitors are thought to have some anti-skin cancer properties, so you might see us change immunosuppression based on a skin cancer diagnosis. Colon cancer screening is just as important in the world of transplant as it is in the general population, starting now at age 45 with new guidelines. Some of our patients might earn a colonoscopy a little bit earlier than that if they're having chronic diarrhea after transplant, or we're worrying about infection in the colon. But otherwise, it should be the normal colon cancer screening with colonoscopy. Then pap smears, mammograms, just as important post-transplant, especially if a woman has had a history of HPV infection, and we really encourage the Gardasil vaccine for both men and women post-transplant. And then looking out for prostate cancer as well if gentlemen are starting to notice signs or symptoms of enlarged prostate. And if you'll remember, in 2022, we talked about how there was a 13% incidence of hepatocellular carcinoma or liver cancer in our transplant population. So you'll look at this graph here shows how we discuss surveillance imaging of the liver transplant recipient post-transplant. So this is by Dr. Mehta out of UCSF, and he created what we call the retreat score. So this is something that we look at when we looked at an explant post-transplant, and we decide what this patient's recurrence risk is based on a couple of things. We look at their alpha fetoprotein tumor marker coming into about 3 months prior to transplant. Ideally, you want no retreat points. So if you have a high tumor marker, you're going to get more points. If we see any type of microvascular invasion, that gives you retreat points. We don't want to see that on an explant. And then we also look at how many viable tumors there are in the explant and how big that viable tumor is. So when we add all these points up in our clinic, you might see a retreat score in a clinic note. If your retreat score is 0, meaning you just had dead cancer in your liver on the explant and no big tumor markers, these patients won't need CT surveillance imaging of the chest and abdomen. But most patients tend to run in a retreat score of 1 to 3, so they'll get imaging every 6 months, the first 2 years post-transplant. Patients that have retreat score greater than 4 and 5 are often also followed by oncology post-transplant, as their recurrence risk can be significantly higher.
So here's a few points just on over-the-counter meds and herbal supplements. As we have alluded to, kidney disease is a major risk and concern in our liver transplant patients. So we generally recommend complete avoidance of NSAIDs. This can be more difficult to manage in these patients who are having acute gout attacks, though we are okay with using prednisone in the setting of acute gout flares over NSAIDs. Liver transplant patients can take acetaminophen. So this is good. Most of our patients know this, but just as a primary care provider, knowing that it's okay for them to take Tylenol, and we would actually prefer it over NSAIDs. Typically, we recommend 2 to 3 grams per day max, and obviously using that sparingly as able. Vitamins, patients love to take vitamins and herbal supplements these days. So any vitamin, we really recommend that they be USP verified, just so there's a bit more monitoring of what's actually in the vitamin. And then running the vitamins by our clinic to try to minimize this as much as we can. Herbal supplements, we generally just tell them to avoid. As Meg mentioned, we have actually transplanted patients for supplement use. So really counseling patients that these supplements that they're buying over the counter are not entirely benign. And many have a list of 20 ingredients with fillers and multiple compounds. So encouraging that it can be really difficult to tease that out, especially with how that's going to interact with their immunosuppression drugs. And then remembering that these supplements can actually cause drug-induced liver injury, and reminding patients of this as well. So vaccinations, given the infection risk post-transplant, ideally, we fully evaluate our patient's vaccination history prior to transplant and try to get them caught up before they undergo a transplant. Obviously, this is not perfect, and and there's always going to be things that they need after transplant. So realizing that they are getting the highest doses of immunosuppression early post-transplant, we generally try to wait at least 6 months before giving them their vaccinations. And that's just to help them mount the best immune response that they're going to. Realizing that transplant patients probably do not mount a perfect immune response, but the philosophy being that something is better than nothing. The exception to that 6-month rule would be annual vaccinations like influenza, COVID boosters. Those would be reasonable to get earlier post-transplant if the season is appropriate. So a few other notes on vaccinations. We do not recommend any live vaccines for transplant patients. Like I said, we recommend annual influenza vaccinations, COVID boosters, and remembering that now the bivalent booster for immunosuppressed patients, we recommend 2 doses at least 2 months apart. We do recommend that patients receive pneumonia vaccination, and now that can be done with Prevnar 20 as a single dose vaccination. We do recommend that all of our patients receive vaccination for herpes zoster or shingles. Being immunosuppressed, they have a much higher risk of contracting shingles, and obviously that's very uncomfortable for them. We recommend that you vaccinate with Shingrix, not Zostavax, as it's a live vaccine. Hepatitis A and hepatitis B, we do vaccinate for these. Hepatitis A, we prefer Havrix vaccination series, and for hepatitis B, there have been some studies which have shown superior immunization rates in patients post-transplant who receive Heplisav, so we prefer that formulation. It's a series of 2, it's a vaccination series that is 2 doses, and sometimes is not readily available in the community. We do have it here at our transplant center clinic, so if you're unable to give it at your clinic, you can always refer the patients to come back to us for that one. And then vaccinating for HPV or human papillomavirus if patients meet age criteria and if it's covered by their insurance.
All right, so now talking about the infected post-transplant patient. It's probably a little intimidating to have a transplant patient come into clinic with fever and not feeling good, and you left feeling, well, what should I do? I wanted to talk briefly about 3 of the infections that we think about a lot in the world of transplant. One being cytomegalovirus. Cytomegalovirus is something that's very prevalent in the community. And post-transplant patients, they're at most risk of getting CMV viremia or in the bloodstream are those whose donor was exposed to CMV prior to becoming a donor, and if the recipient had never been exposed to CMV. These patients are considered, again, high risk for getting CMV, so they're put on Valcyte for the first 3 months post-transplant to hopefully avoid a CMV infection. Patients that also get kidney transplant are actually on this medication for 6 months because they tend to be on higher amounts of immunosuppression than a liver patient alone. CMV, when in the blood, can often present as just a, I kind of don't feel good, I'm a little feverish, I've had some night sweats, I just have general malaise, I just don't feel good, and I can't quite tell you why. Those are usually the things we hear patients say when they have CMV, along with profound fatigue. So we're often checking CMV, and another big tell on their CBC is if their white blood cell has decreased. You'll notice that a lot of our transplant patients have a white blood cell count between 3,000 and 6,000, which is their normal. But if you're starting to see 1,000 and 2,000, that can be a red flag for CMV. We can also see CMV occasionally with tissue invasive disease. So this might be a patient that keeps saying, I'm having a lot of trouble and pain swallowing, or I've noticed that I'm having a lot of diarrhea, or we can even see CMV in the liver tissue when liver function tests are elevated and we can't find another reason why. So oftentimes we're just thinking if someone's coming back and presenting with the same symptom, could it be something not as common like CMV, tissue invasive disease? Now, tissue invasive disease often requires admission and treatment with IV ganciclovir, but viremia can be treated with oral Valcyte outpatient, and patients tend to respond quite well. I spoke briefly about Epstein-Barr virus earlier, and really the only point I want to try to drive home here is if you have a patient that's reporting a lot of B symptoms, fatigue, night sweats, unexplained weight loss, this is something important for us to check. A positive EBV can also tell us that we are maybe over immunosuppressing a patient, and we might back off a little bit. And then it just kind of keeps our eyes out for lymphoma signs and symptoms as well. Our patients who come from either Southern Colorado or New Mexico are at risk for coccidiomycosis. This is also known as valley fever. So you'll see that our patients are on fluconazole for the first 6 months post-transplant. Very important if you see one of our people in clinic and they're not quite at 6 months and they say, oh, I haven't taken that med in a couple weeks. If you don't mind having that patient let us know, because that means their tacrolimus level is probably quite low and they're at risk for rejection. And then cholangitis, that's a big one for us to think about, as we talked about earlier in the slides, if they have any biliary history. And then, of course, the other things that any patient can get, things like UTI, bacteremia, pneumonia, and we'll talk a little bit about more of that here in a second. And this slide is just to show that we tend to see more bacterial infection early post-transplant, and that would be with leukocytosis on your lab work. And if we're thinking more viral, that might be a little farther out past the first month of transplant. And again, if you see that leukopenia, really be thinking about a viral illness. So if you have an infected transplant patient in your clinic, what could you do? Things that are very helpful are getting a CBC. Again, to say, are we on the leukocytosis pathway, thinking about bacteria, or should we be more on the viral pathway with leukopenia? A CMP can be helpful. Let's look at the kidney function. Is that elevated? Should we be thinking about UTI? Are they having urinary symptoms? Getting a UA with culture can be really helpful. Or are their alkaline phosphatase and bilirubin elevated? Do we need to be thinking about cholangitis? What's really helpful is with fever is to get those cultures, whether it be blood or urine, and having cultures and sensitivities. This really helps us, especially when patients are starting to get recurrent infection, with choosing the appropriate antibiotics. And also then deciding on imaging is important as well. If they're sitting there with cough in clinic, by all means, a chest x-ray is important. But if we're seeing abdominal pain also, we might think about imaging. These are things that we would like to help you with. That way we can just get the right testing done initially. But that initial blood work can be really helpful. Also in the world of transplant, thinking about concurrent infection. These patients can have CMV and C. diff, bacteremia and C. diff. And I keep saying C. diff a lot because it comes up a lot. And we ask that if patients have diarrhea, that they get a GI PCR to exclude an infectious etiology before they are encouraged to start something like Imodium or Pepto-Bismol. And in fact, we prefer Imodium if they're going to use an antidiarrheal agent. So getting that stool study is really important. And if we're seeing a negative GI PCR, that's when we might start thinking about, okay, is mycophenolate contributing to this diarrhea? Do we need to think about CMV in the colon? Or does this patient maybe need a colonoscopy? And we just ask that anytime new antibiotics or new agents are being started, that either you or the patient reaches out to our team, because again, there can be some of those hidden interactions with immunosuppression. We also ask that you do not reduce immunosuppression in an infected transplant patient. Exceptions might be if they're septic in the hospital, of course, but in the outpatient setting, we'd like to take control of all immunosuppression management just to make sure we're doing things carefully. The worst thing we can do is lower immunosuppression, cause rejection, and then we're using Solumedrol in the setting of someone also having an active infection. So letting us know that you're concerned about infection is really helpful. And as Brittney mentioned earlier, if you have a post-transplant patient and you see they recently got thymoglobulin and they're telling you about their upcoming trip to Disney World, please tell them to reschedule, because they are going to get very sick if they are, touching things at Disney World with thymoglobulin recently in their system. And lastly, just thinking about the transplant patient that can go from feeling a little punky to becoming septic pretty quick. So please don't feel like you're over calling and asking us questions if you're worried about a transplant patient being sick in your clinic.
So now we'll review some of the metabolic risk factors for post-transplant NASH. It's important in this scenario to think about the patient's original indication for transplant. So obviously, if they were transplanted for NASH, their risk for developing NASH post-transplant is quite high. But also, this is a country with an obesity epidemic. So realizing that all of our patients are actually at risk for post-transplant NASH. So again, thinking about diabetes, making sure that we have their diabetes as well controlled as possible with that A1C below 7 as able. managing their cholesterol, so the LDL goal below 100, less than 70 in diabetics, and remembering that we can use statins as an agent to help manage their cholesterol. Hypertension, keeping that blood pressure below 130/80, and reaching out if you have questions about drug management, but using medications as needed to help control their blood pressure, and then weight management, whether through lifestyle modification counseling and weight loss agents such as the GLP-1s as covered by insurance. That yes, we really just rely on primary care providers to help us in this, because you're seeing these patients more often. You're aware if they're gaining weight, if they're struggling with poorly controlled chronic illness. This can really help the long-term outcomes of their transplant. So monitoring for fibrosis. This image here in the middle depicts NASH, though obviously the reason for their liver dysfunction could be due to infection, due to chronic rejection, due to post-transplant alcohol use. There could be a variety of conditions there. So on the left, we see normal liver tissue, this progression to liver dysfunction all the way up to cirrhosis. So we scale this fibrosis on a scale of 0 to 4. F0 would be that image there on the left with no fibrosis, all the way up to F4, which would be that image there on the right with cirrhosis. So we have a technology called transient elastography, or FibroScan, can also be called shear wave elastography, that we use an ultrasound to assess for density changes in the liver consistent with scarring. So this is a non-invasive way to assess for fibrosis. And you can see this image there on the right. We use statistical software to translate the ultrasound readings to one of those fibrosis scores, so the F0 to F4. Obviously, this is nice, it's non-invasive. Liver biopsy would still be the gold standard, but this can be helpful in kind of further teasing out what might be going on with a patient who you suspect recurrent NASH or some kind of fatty liver changes or just liver dysfunction scarring. So post-transplant advanced fibrosis. So remembering that that's going to be the stage 3 and stage 4 fibrosis, that's depicted by these histology stains here. The two on the far right are stage 3 and 4. In these patients, we want to do hepatocellular carcinoma or HCC surveillance imaging, as they are at increased risk. Typically, that will be done annually via an ultrasound or cross-sectional imaging. We also screen these patients annually for esophageal varices via EGD, and then monitoring for symptoms of portal hypertension, whether that be ascites, edema, new onset confusion that could be hepatic encephalopathy, just a little bit of extra surveillance for these patients who we know have poor graft function. So if we have a patient with advanced fibrosis or post-transplant cirrhosis, could they receive another liver transplant? And the answer is maybe. So the patient would need to be under 70 years old. They would need to undergo cardiac evaluation to ensure that they're an acceptable candidate for surgery from a cardiac perspective, and then undergo extensive vascular evaluation to assess their vasculature, to undergo another surgery, thinking about all of those arterial and venous anastomoses that we reviewed at the beginning. If you're going to make those again with another transplant, obviously you would want to make sure that that would be feasible. And then thinking about how they got to this point. In a patient with something like PSC, it could be that it's a recurrent disease, or is it post-transplant alcohol use? Have they been compliant with follow-up visits? Have they had labs frequently? Do we think they take their immunosuppression? Can all be things that we think about when deciding whether a patient would be appropriate for retransplant. And if the thought is maybe, we will again put them through that extensive evaluation that they go through the first time to receive their liver transplant. So they would come in, they would have labs, they would have cardiac and pulmonary function testing. They would meet with members of our team, so the transplant surgeons, the hepatologists, the social workers, potentially a transplant psychologist, the dietitian, and then also our pharmacy team. All right, now quite possibly the most important slide in this whole presentation is,
how the heck to get a hold of us if you ever need us. For inpatient management questions, worried about emergency things, if patients maybe need to be admitted or transferred to the hospital, please utilize our doc line, phone numbers up here for you, and ask for the on-call hepatologist. We're hopeful that most questions can actually be answered by calling our outpatient clinic. Please ask through the phone tree, which can be a little frustrating and annoying. I apologize in advance. To ask to speak with one of the liver transplant coordinators, or Brittney or myself, so one of the advanced practice providers. This is really great for non-urgent questions that can wait at least 24 hours for us to get back to you. Or if you just have generic, plan of care questions or maybe surgical clearance, this is a great way to get a hold of us. I also want to take a minute to give a huge shout out and many kudos and thank yous to our liver transplant coordinators, who are phenomenal. Without the 7 of them, we would all be lost. And I think I can speak for our attending physicians as well. So our liver transplant coordinators have such a wealth of knowledge, along with our clinical pharmacist, Dr. Sonia Lynn. So big thank you to everyone, and that helps us take care of all of these patients. And then lastly, you can put some responsibility in the patient's hand too. Many of our patients sign up with My Health Connection. They can send us a message and say, hey, my doctor just started me on a Z-Pak. And I'll be like, please ask for doxycycline instead. But that's a great way. We know you're very busy in your clinics and you're seeing a lot of patients yourself. So having the patients reach out to us as well is also another option. And before we do questions, want to give a quick plug for a live in-person event in this webinar series. This will be Thursday, June 1st. Amy Brumanchenko and Lindsay Pratt giving a talk on when to consider liver transplant, followed by some education on Barrett's esophagus with Miss Katie Dickerman at Maggiano. So come get some good food and learn a little bit more. And then also another free CME option, which with this great series, is Saturday, August 5th, the Rocky Mountain Highlights in GI and Hepatology. So all of these things are free CMEs, which is a pretty awesome thing to get. So make sure to sign up. And with that, here's Brittney and I's email addresses, and we can open for any questions. So I think.
So one of the questions we got, are there racial differences in post-transplant skin cancer rates? What are the rates for African-American, American Native patients compared to all races in the post-transplant population?
So I don't have good hard statistics to give you, but I would say that we do see skin cancers in African-American population and in Hispanic population. I would say it's probably more prevalent in our white population, especially people of European descent, the Irish, Scottish, people that are just more prone to skin cancer in general, but also those patients that are on, say, the anti-metabolites, your Imuran, your mycophenolate. Those patients can really have the highest skin cancer risks, even really regardless of race.
We also have one other question. When are you worried about a potentially infected post-transplant patient in clinic? When would you recommend fungal blood cultures?
Ooh, that's a really good question.
I don't know. I mean, fungal cultures, I think, are useful, though they typically take quite a while to come back. So I don't know that we necessarily need to be getting fungal cultures with every set of blood cultures. Though I think if we're worried enough that we were starting an antifungal agent, number one, if it's fluconazole, tell us. And number two, then potentially the threshold will be higher that, potentially do they need to be in an inpatient setting to get further evaluation? Do we need our infectious disease colleagues to be helping in their decision making?
And I think another thing to possibly consider is if, let's say you're in a high area for coccidiomycosis, let's say you have a patient that does a lot of work in the soil, or they're in the wind a lot and their exposure risk is higher, we could always get a cocci antibody to see what their antibody levels are. And if we're then, worried, then maybe moving on to cultures. But I think oftentimes, like Brittney just said, if we're thinking about fungal infection, we probably have transplant infectious disease helping us at that point. But really great question.
Yeah. One of the other questions we received is a preferred imaging study of the abdomen, ultrasound versus CT, for PCP to obtain when we see post-transplant patient in the office with fever?
So I say that's another great question. I think there's a couple things that go into consideration for that. being what has their transplant infectious history looked like? Is this someone that we know has had an abscess of the liver before, and we might benefit from jumping straight to cross-sectional imaging? Or is this someone who has fever and they've never really had any transplant complications? Usually ultrasound is a really great way to start. It's less expensive. Insurance usually covers that first ultrasound. And if you're pretty concerned about the patient, please call us and we could talk through and do a quick chart review of when the last time we had imaging on that patient was, and try to be helpful. If you have a patient that maybe has recurrent PSC or a big bile duct history, actually getting an MRI, MRCP is the best way for us to look at the biliary tree. But I think at that point, that's something we could be helping with, because we're probably looking at deciding then on ERCP and stuff that we wouldn't want you to feel tasked with having to make decisions on.
Yeah, I think the only other thing, timeline of how quickly we can get the patients in for imaging. If ultrasound, they can do same day, potentially that's a more appropriate place to start. And then also if we're thinking about any CT with contrast imaging, remembering their renal function.
And then it looks like, are you doing fiber scans at regular intervals for patients post-transplant or only worried about by lab values? Another really good question. There are some transplant centers and some pediatric transplant centers that do annual fiber scan just to get an estimate of if we're seeing scarring in the liver. We tend to use it more if we are concerned about NASH in a patient or someone that's had extensive rejection. In patients that get liver biopsy, if we're able to capture a fiber scan around the same time and those values line up, then we can use the fiber scan a little bit more as a marker that we trust a little bit more. The hard thing with fiber scan and biopsy is you're capturing just that one area that you look at in the liver, and sometimes people can have geographic changes in their fibrosis as well. So we don't tend to use it as a routine thing on every patient.
One other question that we got, if a patient who moved here to Colorado and previously had a liver transplant with another team, are you willing to see them to establish care? Or do you have other recommendations, especially if they have a history of liver transplant rejection? This is an excellent question. The short answer is yes, we do intake patients who are transplanted elsewhere. Typically, we like them to be at least 1 year post-transplant and to have some stability of their graft. So if they were recently discharged from their center in Utah and received rejection treatment and had an episode of cholangitis with bacteremia, they have a lot of moving pieces. They're probably more well served by following up with their transplant center. But if they're several years out, have been doing really well, and they've just been communicating with their transplant center via phone and want to have a face-to-face team that can manage them, we often do intakes, and it's been really nice to meet some of these patients.
And we also support New Mexico for liver transplant as well. Brittney and I and most of our hepatologists are also licensed in New Mexico. So since there is not a liver transplant program there, we're happy to take patients that are residing in New Mexico as well. But yes, there are some programs that do not do intakes into their program, but we're happy to help where we can, absolutely. And we actually go to clinic in Albuquerque once a month to specifically see post-transplant patients. So if there's someone that you want us to prioritize getting a clinic appointment with because you're worried about them, please don't be shy and let us know, and we can see them in our Albuquerque clinic.
Great. I don't see any other questions, but definitely feel free to reach out to us via phone, email. We're happy to communicate with you, and it's always really nice to communicate with primary care providers. You all are a wonderful asset to us taking care of these patients in the long term. So appreciate all that you do.
Couldn't do it without you, that's for sure. So I think that might be it.